I am Elizabeth Felton. I'm at the University of Wisconsin, and I'm going to talk today about advancing health equity in epilepsy, a very important topic. I don't have any relevant disclosures. And our objectives today are to describe a little bit about health disparities, health equity, and social determinants of health, give some epilepsy-specific examples of progress in this area, and talk about some action items to advance health equity. So we've seen this 3 or 4 times today, the list of IOM recommendations. What I want to point out here is that none of these recommendations specifically call out health disparities or health equity. However, many, if not all of these, can sort of be worked into that realm. And we've heard about some examples of that already today in the prior presentations. And so the report from 2012 was 568 pages. I don't think anyone talked about like how thick this was. And so I kind of did a little keyword search on the report. So how often are we talking about equity and disparities directly in the content of the report minus the references? And so equity was used 14 times, disparities 38, and determinants 1. I think if the report were to be rewritten today, we likely would see much different numbers. And similarly, there's been some evolution in the language that we use to describe this area. So if we look at PubMed citations as a proxy for how our language has evolved over time, and we have on the x-axis here years, I know it's small, but it's from 1945 to 2022, and then on the y-axis is results per 100,000 citations in PubMed for health disparity in blue, health equity in red, and social determinants of health in yellow. And so the takeaway here is that we really weren't talking about this at all, until maybe 30 years ago. And then there was a big increase first in health disparities and more recently in health equity and social determinants of health, and even more so in the last couple of years in light of the COVID-19 pandemic and social justice things going on. And if we look just at the last 10 years, so just of the years of the IOM report, you'll also see these similar trends, particularly with health equity in red kind of increasing. And I also did this putting in epilepsy as a search term, so I don't have it to show, but it followed a very similar trend. And so I just want to talk briefly about each of these terms. So health disparity is a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. And they adversely affect groups of people who've systematically experienced greater obstacles to health based on a variety of factors listed here, including race, ethnicity, socioeconomic status, et cetera. And you might try to consciously or unconsciously try to explain these things away in ways that don't involve bias or racism, but unfortunately these disparities persist even when corrected for all sorts of factors. And so what does this look like in the field of epilepsy? We've seen already some examples today, and I'm not going to go into any of these in detail, but I have just titles of about 10 different articles that have come out over the last few years over the course of the IOM report that have highlighted these. We're just talking about it so much more and identifying these things. So disparities in the nationwide distribution of epilepsy centers. So of course, rural areas have fewer epilepsy centers and there's more disparities there. Socioeconomic disparities in SUDEP. Families living with epilepsy, or disparities disparities in families living with epilepsy are significant and linked to socioeconomic status. This article is excellent. This facets of health disparities in epilepsy surgery and gaps that need to be addressed. So we're not even offering epilepsy surgery as often to people from certain racial and ethnic groups, and nor are they accepting it. And so why is that? And this article goes into that quite detailed. Delays and disparities in the diagnosis. So even just getting a diagnosis in the setting of like the same information, there's a delay in diagnosis for certain groups of people. Again, epilepsy surgery underutilization. Clinical trials. Who are we enrolling in our clinical trials? Significant underrepresentation of people from underrepresented backgrounds. This one was called out in one of the talks earlier, the burden of chronic and acute conditions in people with epilepsy. So things like hypertension and depression and being higher in certain racial and ethnic groups. And then in the MMWR, barriers and disparities in access to care. And so this is a big problem. There's been a ton published about this over the last 10 years or so. But where are we kind of going with it? So we have to look at health equity. So health equity is the attainment of the highest level of health for all people. We want everyone to attain a high level of health. And doing this requires valuing everyone equally with focus and ongoing societal efforts to address these avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. That's how we get to equity. And you've probably seen over the years there have been a variety of graphics that have depicted what equity is. There was like the children along the fence, and that has evolved over time. And here's one, a newer one from the Robert Wood Johnson Foundation on the left showing equality. So equality is you have these 3 people in 3 situations, and you give them all a bike. So we've given them all the same thing. That's good enough, right? Well, not really, because look at the terrain and the circumstances around them. It's not all the same. So equity is giving them what they need to address whatever is in front of them, whatever barrier, circumstances, or conditions. And so social determinants of health is also something that we've heard a lot more about recently. And so these are the conditions and the environments where people habitate, where they live, learn, work, play, that can affect their health and quality of life. And addressing these is a primary approach to health equity. And so this graphic on the right is from Healthy People 2030, and it highlights 5 domains of the social determinants of health. And so this means focusing on the resources needed to maintain health and quality of life. And so examples of these can be safe and affordable housing, high quality education, healthy foods, local health and emergency services, and environments free of life-threatening toxins, things like that. But just promoting healthy choices won't eliminate these and other health disparities. We need public health organizations and their partners, so kind of everyone here, to take action to improve the conditions in people's environments. And we'll give some examples of that. So this is from the CDC, the Essential Public Health Services Framework. And this is the original framework from 1994. And again, you won't see anything directly talking about health disparities or health equity here, although it's related. But if we look at the updated one from 2020, now we see equity at the center and everything else around it. And the goal is to protect and promote the health of all people in all communities, so health equity. And I'm not going to go through everything here, but I'm going to call out the 2 that are in blue. So one is to build a diverse and skilled workforce, and the other is enable equitable access. And so we'll get some examples of that in a moment. So this is also from the Robert Wood Johnson Foundation. It's a framework called Raising the Bar, and it's talking about things that we can do to promote health equity. And so it goes into like your role and some specific actionable items that you can do. And so I recommend taking a look at it. I think there's some great suggestions here, and I'm going to go through some examples. So the role of a provider, a healthcare provider, the goal is to provide whole person care to achieve health equity. And so an action item could be establish and sustaining a trusting environment where everyone feels they're welcomed and treated with dignity and respect. So an example of that would be learning about implicit bias. And so this is also an area that there's been a lot of talk about, and this could be a whole separate 1-hour talk on this topic. But there's been a lot of data and studies that have shown that this affects healthcare provider behavior, and likely is a reason for a lot of the epilepsy healthcare disparities that I spoke about earlier. And patients perceive this bias even if you don't. And so we hear a lot in these publications about certain racial and ethnic groups having poorer medication compliance or adherence. And a lot of times it just stops there, like period. But well, why is that? And what are perhaps we doing that could be contributing to that? And I think we really need to think carefully about our role in these disparities. The caption for this photo, or this picture, this graphic here, is the emotional toll of negative experiences can lead Black women to distrust doctors, and eventually some people stop going. So again, the ER calls and says, so-and-so is back with more seizures or non-compliant with their medication. I think we have to think about maybe there's something that we've done that has contributed to that. And to that end, the American Academy of Neurology has an anti-racism education program. This is just one example of some content that people that are American Academy of Neurology members can take. It's free. There's some modules that go through this, and with a neurology-specific lens, which I think is helpful. So now the role of the employer. So employing and support a diverse health workforce as a way of improving health equity. So investing in and growing leaders who advance and embed equity, quality, and value across the organization. I can give a very recent example of this with the American Epilepsy Society just hosted a 2-day leadership training for new leaders into the organization and like committee chairs and things like that. And really throughout that leadership training, it was very clear that the AES has, as part of its core values, diversity, equity, and inclusion, and they want to make sure that the leaders are aware of that and that they're also thinking about that when they're getting their committee together, when they're inviting panelists, the content that is talked about in the annual meeting. And that's really important. And so that's like at the employer level, but that's going to improve ultimately downstream patient health equity. And then employing and cultivating a representative workforce at all levels. And I just want to briefly show you what the neurology demographics look like over the last 10 years. It's not the exact same time frame of the IOM report, but it's close. So I'm going to have you look at the right side of this, where it says U.S. neurologists in 2008 and 2019, and the demographics. So female increased from about a quarter to about a third. So that is certainly growing. It's still not 50-50, but some improvements there. But you can see there have been more progress in some areas than others. So Hispanic or Latino neurologists increased from about 5 to 7%, Black or African American only from 1.7 to 2.8, and American Indian and Alaskan Native actually decreased from 0.6 to 0.5%. So this is a big problem. And it's especially a big problem when we compare it to the numbers in the US population. I would say at minimum we should be able to match what our US population is in terms of our neurology workforce. So US population is 13% Black. This is in 2019, and US neurologists is 2.8, and you can see the data for the other groups there. And so this is something that we really need to do something about. And the reason is that intervening at the workforce level can actually reduce disparities and health equity downstream. So there have been studies that have shown that there's better patient outcomes and promotion of health equity when there is a more diverse workforce. When oftentimes when a healthcare provider and the patient have the same racial ethnic background or same sexual identity, there can be improvements in satisfaction and patient care. And that's kind of highlighted in this quote here, which I won't read, but it's just something that we really need to consider. And so how do we do this? Pipeline programs, mentorship, and just a couple examples of that. So the picture on the left side is of a student who participated in the AES Summer Research Internship Program this past summer in Dr. Farah Lubin's lab. And she's here presenting her research and will be part of the Bridge poster session a little bit later. So this is one way that we need to increase the pipeline. I personally think we need to start much younger than that at the elementary level. And so that's actually my daughter, but I went to her school, and we showed the kids human cadaver organs and did some education with them. So we got to start early with this. Okay, so moving on to a partner. What can a partner do? So engage with organizations and community residents, prioritizing those most affected by inequities. And so I'm just going to give one example of this. So many of you have probably heard of the Uplift program. It's a self-management program for treating depression in people with epilepsy. It's a home-based program over the phone or internet. They do CBT and mindfulness. And the program, this paper goes into how the program was adapted for the Hispanic community. And there were 72 with depressive symptoms who were randomized to Uplift or usual care. Content was delivered in English and Spanish. They had a very high consent and retention rate. And they showed through 12-month follow-up that the rates of depressive symptoms were lower in that in the cohort that had gone through the Uplift program many of them with a Spanish-speaking provider. And so, like, this is an example where there wasn't equity before, right? So if you are, largely delivering this in English and people that are Spanish-speaking aren't able to participate, that's not equity, right? But now let's have Spanish-speaking providers come and provide the content, and now they're also able to get some improvement in depressive symptoms. And so I think something like this could be expanded, of course, into other languages, looking at provider similarities in other realms as well. And then on the advocate level, so advocate for and invest in health equity. And I want to call attention to the two highlighted ones here. So using healthcare's voice to shape public understanding about the importance of health equity and dismantling racism and all forms of discrimination, and using power and influence to advocate for health equity and the development and implementation of public policies. So it's not enough for an organization or a hospital to kind of privately think that these are good things to do, but using their platform to publicly talk about this has the benefit of both people from the underrepresented groups hearing that the organization is kind of working on these areas, and then people not from underrepresented groups, learning that as well and kind of having the collective understanding. Like, we're not going to make progress until there's more of an awareness in this area. And so AES has done a bunch of initiatives, and in the interest of time, I'll probably fly through some of these because we heard about some earlier, but this is the AES strategic framework, and you can see at the center here, maybe you can't because it's small, but diversity, equity, and inclusion are at the center of it. Just like in that updated CDC guideline I showed you, equity is at the center because it impacts all of these areas, and there's work to do in all of those areas from a health equity lens. The AES over the past couple of years has had a gender diversity task force, a DEI task force, and now committee. In June of 2020, in light of various social justice things going on in the United States, the AES put out a statement about health disparities. I think this is just a great example of an organization like speaking out, using their platform to say that to call attention to this. And that was done similarly here. These were written comments to the NINDS request for information on input on health disparities. And at the bottom in italics is kind of what the AES said, is that they remain concerned that access to state-of-the-art treatments and subsequent outcomes are not uniformly available to patients with epilepsy and their families, particularly variable access based on race, ethnicity, et cetera. At the meeting, you could filter by session content and look at DEI content. There's 18 sessions that come up. This has just been increasing every year, particularly in the last few years. The Bridge poster session is today at 5:15, if everyone could try to come to there later. This is spotlighting research relating to the needs of the underserved populations and also showcasing work of investigators who identify with those groups. And so I hope to see you there. And then there's a new SIG, Health Disparities, Moving Beyond Talk into Action. So that's kind of what I'm talking about here, is kind of, let's not just talk about it, let's do something about it. And that's tomorrow morning, and they'll be getting into that as well. So this is my last slide here, what's coming next. So I do believe the 2012 IOM recommendations, so they did not specifically call out health disparities or health equity, absolutely played a role in advancing it in all the research and studies that have been done over the past decade. Incorporation of equity into the center of these frameworks for public health and epilepsy-specific initiatives is really important for increasing public awareness and just really putting it top of mind for all of us. Health disparities do persist, so we still have a lot of work to do. It's just beginning. It's not like even close to being over, but we're starting to shift beyond just describing the problem and taking action now. And we really need to engage with the communities most impacted by these health disparities, and then intervening at the workforce level as well. So I just want to thank the National Academy of Medicine, the Epilepsy Leadership Council, and everyone else involved on the panel, and my contact information is there. Thank you.